medical team of Boehringer Ingelheim India, and I extend a very warm welcome to all our faculty, speakers, and all our attendees for joining today's CRM symposium, which is sponsored by the Orange Medical Foundation of Pune, India. And with this, I take this pleasure to introduce Dr. Shailaja Kare ma'am. She is Director of SKDC Diabetes and Specialty Clinic and also the Director of Orange Diabetes Medical Foundation and Research Center, Pune. She's also been the Professor in Internal Medicine and Consultant Diabetes in KM Hospital, Pune till 2023. Ma'am is also felicitated at Trinity College, Dublin at Tricentenary 300-year diabetes program. She also has many awards in her credentials. To enlist few recent awards, she is awarded with Surya Datta Sri Shakti Rashtriya Puraskar in the recent year of 2023. Ma'am, it's a privilege to have you with us in today's CRM symposium. And with this, I invite you to moderate the further session. Over to you, ma'am. Thank you.
Thank you, Nikita. So welcome everyone. Welcome for this diabetes dilemma, a very interesting session today. As we all are aware that diabetes dilemma, there is a website, www.diabetesdilemma.com, and all the interesting lectures, brainstorming sessions, which we have some hybrid programs. All our videos are uploaded on the website and anyone can watch. So let me tell all my attendees today that you can watch all the past programs for last 3-4 years on our website. Today, I'm very happy that we have a very interesting session and two great speakers. So I think everyone is looking forward. Let me have a privilege to introduce both of them. My first speaker will be Dr. A.G. Unnikrishnan. Welcome, Unni, for today's program. And Dr. A.G. Unnikrishnan is an endocrinologist and CEO of Chelaram Diabetes Institute, a leading diabetes institute in India. He is also mainly associated with its research center, which he has started, one of its unique research center, I think, across India. It's very different from other institutes. A lot of research happens. He has more than 220 PubMed indexed publications for his credit. He received numerous awards, lot of prestigious awards. He has published main largest multi-center study for the pancreatic and pancreatic diabetes. Also, we have read his book about pancreatic diabetes. Dr. Unnikrishnan has edited various journals like Indian Journal of Endocrinology and Metabolism and Journal for Thyroid Research and Practice. He is the editor-in-chief for the Journal of Chronicle of Diabetes Research and Practice. So welcome, Dr. Unnikrishnan. Our second speaker today will be Professor Dr. Merlin Thomas. Welcome, Dr. Merlin, for Diabetes Dilemma. Dr. Merlin is Program Leader, Department of Diabetes, Monash University, Melbourne, Australia. Head Molecular Scientist, Biochemistry of Diabetic Complications Laboratory. Specialist in both nephrology and endocrinology. He is internationally recognized clinician. So I think it will be very interesting for all my colleagues to attend your talk, because as a clinician, your insight for every scientific thing will be very interesting for us to listen. He has more than 300 publications, many in the highest ranked journals in his field. And he's a best-selling author of The Longevity List and Fast Living, Slow Aging. So it will be interesting to see that.
Thank you for having me on.
Yes. So today, to set the context, what we are going to discuss in next 40-45 minutes. We all see these young people in our clinics every day who are young, have lots of adiposity. They usually have a very high baseline A1C when they get diagnosis of type 2 diabetes as a typical Indian type 2 diabetic person, which says very low baseline beta cell function. It's a very rapidly progressive kind of a diabetes in India. And as a particular form may be described in the clusters as a combined insulin deficiency and resistance, or at least severe insulin resistance and also deficiency, which comes with obesity and also adiposity. So we see so many patients who just come, gets newly diagnosed, develop proteinuria and progress to end-stage kidney disease in front of our eyes in just 4 to 5 years. As A1C progresses, even complications progress very fast. So this is a very, very common kind of a patient which we all are facing today, and it's our responsibility to help them. The adiposity which we talk has more fat spillover We all know it is inside pancreas, muscles, pancreas, around the big arteries as a perivascular fat, as well as around the myocardium, which has a direct correlation with the cardiovascular and the kidney risk. As a direct, which is independent of other standard risk factor for the cardiovascular or end-stage kidney disease. And this particular type of type 2 diabetic person, which we see, has a very high risk of chronic kidney disease and also the heart failure. So what we are doing good in our practice with lot of standard medications, but what we can see is the patients who are young, diagnosed here at a young person, as a young person, and their progression is so rapid, they reach CHD equivalent stage very fast early in life. So these are the individual I was talking about, as well as untreated. This red box are diagnosed people, but untreated, they also reach CHD equivalent very fast. So it is becomes treating physician's responsibility. We are doing very well by treating standard kind of a blood pressure, good control, good A1C control. We have good medicines for as anti-thrombotic kind of a tendency. We use antiplatelets. We use very good molecules, SGLT2 inhibitors. Thanks to Indian pharmaceutical industry that we have these molecules available as also as a cheap version, which is affordable. So we are doing well as a main focus for our patients. But what we are lacking our focus is the treating this ectopic fat, adiposity, and obesity, and for which we need special attention if we really want to focus and prevent this heart failure as well as the patients with the chronic kidney disease. So let's discuss how we can help these young people and how we can prevent. So at the outset only, I would like to thank Nikita as well as Professor Merlin Thomas. I'd like to thank Dr. Unnikrishnan and also to thanks to BI. So let's start first. Let me invite Professor Unnikrishnan first. So Unni, you can share your slides. You are mute.
Thank you, ma'am. I hope my slides are visible.
Yes.
And I'm audible.
Yes.
First of all, let me thank Madam Dr. Shailaja Kale for this wonderful meeting. And I think Diabetes Dilemmas is one meeting I really like because it looks at very clinically relevant topics, sometimes controversial, often debatable, where people discuss the nuances between evidence and practice and take home messages are there for practicing doctors. I have participated in this meeting many times, and I thank Madam for that. And it's a pleasure to be here again. So my task is to look at a holistic cardiorenal metabolic care, optimizing kidney protection with SGLT2 inhibitor. So if you look at the data, this is from the Ministry of Health and Family Welfare. A national health policy goal is to ensure a 25% reduction in premature deaths in India by 2025. And what is the leading cause of death? The leading cause of death is cardiovascular death, and that is from the India state level disease burden initiatives. And type 2 diabetes increases the risk of cardiovascular death by 3 to 4 times. So there are several stages of the cardiovascular kidney metabolic syndrome. From a stage of no risk factors, you have dysfunctional adiposity. You know that the adipose tissue is the largest endocrine gland in the body, not in terms of the size alone, but in terms of the number of hormones it produces, like interleukin-1, interleukin-6, TNF-alpha, all the components of the renin-aldosterone angiotensin axis. And this leads to a clustering of metabolic factors in CKD, eventually leading to a subclinical CVD syndrome and then a full-blown CVD syndrome. This is a paper I published about 2 years ago in the PLOS One, where we studied newly diagnosed type 2 diabetes patients in India, and we found that a large proportion could be classified as very high risk or high risk because the Lipid Association of India classifies diabetes itself as a high risk state. So that was one, but the other interesting finding was there was a lower LDL, hypertension, smoking and tobacco use, higher prevalence of CKD stage 3B or higher, and also at least one person, at least 82.5% of people had at least one cholesterol abnormality. So overall, people with type 2 diabetes newly diagnosed in India are at high CV risk. And this is another evidence published in the American Journal of Cardiology looking at South Asians, and they found that the risk of coronary artery calcification and more than 50% stenosis were both higher, and 2 out of 5 asymptomatic people with type 2 diabetes may have coronary artery disease. If you look at this consensus statement, it talks about stage A, stage B, stage C, and stage D, and goes on for 4 different stages of heart failure, from at risk to pre-heart failure to heart failure to advanced heart failure. I want you to look at just the pre-heart failure, where there are no current signs or symptoms of heart failure, but there is presence of one of these: structural heart disease, functional cardiovascular anomaly, and raised NT-proBNP or other markers. Of course, by the time stage C has occurred, symptoms have occurred, and by the time advanced heart failure has reached, there are recurrent hospitalizations. But it's important to target to see the patient at stage A or stage B and prevent the disease before it has actually happened. 46% of people with type 2 diabetes have diastolic dysfunction. This is a meta-analysis of 27 echo-based studies, and you can see that this is the pooled prevalence, and 46% of type 2 diabetes have LV diastolic dysfunction, and guidelines recommend routine microalbuminuria. So coming to a prototype case vignette of a 50-year-old male patient recently diagnosed with type 2 diabetes. The BMI is 30, has hypertension, dyslipidemia. The HbA1c is 7.9%. The LDL is 92. Liver enzymes are raised, suggesting metabolic dysfunction associated steatotic liver disease. You can see the urinary albumin creatinine ratio is 90, and there is a decline in EGFR. The ECG shows a stress test that is positive, and the echo shows grade 2 diastolic dysfunction. This gentleman is on metformin, telmisartan, amlodipine, atorvastatin in tolerated doses. You can see that intensive glucose control in type 2 diabetes reduces microvascular events, but may not have an impact on cardiovascular death or mortality. That brings into picture the need for holistic approach, which looks at cardiovascular, metabolic, and renal as one continuum of disease, and looks at lifestyle modifications, classical treatments, and newer treatments, including SGLT2 and GLP-1RA. You can see the effect of SGLT2 on the pathophysiology of cardiovascular disease goes from preload reduction, where it reduces the blood volume, the interglobullar pressure, the increases the free water clearance, to the effect on the myocardium, where it improves the metabolic efficiency, increases the diastolic relaxation, reduces left ventricular hypertrophy, reduces LV remodeling, and reduces fibrosis. Thereby, it also reduces the afterload by decreasing vascular stiffness, decreased neurohormonal stimulation, an improvement in autonomic imbalance, and an improvement in endothelial function. So by preload reduction, myocardial effects, afterload reduction, the SGLT2 inhibition translates into an improved cardiac structure and functioning, and that result was clinically translated in the very well-known EMPA-REG outcome study, where there was a 38% overall risk reduction in a patient with an event, and the Asian subgroup saw an even better. The hazard ratio was 0.44, suggesting a 56% relative risk reduction over 48 months. You can see the person with people with an event was much lower in the empagliflozin group compared to the placebo group. Empagliflozin also reduces the first and recurrent CV events, and there's a 21% reduction in myocardial infarction, and of course, there was a reduction in MACE as well. Whenever a drug reduces cardiovascular death, you sit up and notice the drug, because not every drug can do that. So in addition to the major adverse CV events, which EMPA and CANA did, in addition to the reducing the hospitalization for heart failure, which almost all the agents did, reduction in kidney outcomes, which all the agents did, I think only empagliflozin reduced the all-cause mortality, and most important, empagliflozin is the only drug among the SGLT2 inhibitors to convincingly reduce a cardiovascular death in the EMPA-REG trial. Empagliflozin also reduces CV death or heart failure hospitalizations across a spectrum, whether you take HFrEF or HFpEF or HFmEF, whichever group you take, there is a reduction. And the European Society of Cardiology guidelines recommend empagliflozin over all the LVEF categories. If you look at the American Diabetes Association, there is a very strong recommendation for empagliflozin or SGLT2 inhibitors, where it talks about ASCVD, high-risk subgroups, heart failure therapies, and in all these, they've suggested a drug with proven heart failure benefit in that population, and therefore, empagliflozin gives a benefit. And there are also benefits on glucose lowering, effects on MACE, heart failure reduction. Well, I think every drug comes with pros and cons. So there is a risk of volume depletion, recurrent UTIs, genital infections, euglycemic DKA. But I think these are by far rare, and we have so many years of experience with these drugs. And you can see of course, we shouldn't be using it in pregnancy and breastfeeding or in type 1 diabetes. But beyond that, coming back to this patient, the young, relatively young, well, he's 50, recently diagnosed type 2 diabetes with hyperglycemia and elevated liver enzymes, declining eGFR, a high UA albuminuria, a positive treadmill test, diastolic dysfunction. You can see a clustering of risk factors suggesting that he is at risk of heart failure, if not in the earlier stage of heart failure, where there are structural and functional abnormalities, but without any symptoms. So I think this puts into place the importance of choosing the appropriate therapy for the appropriate disease. Earlier, we were talking about controlling glucose, but now the treatment has moved on from glucose control to organ protection. And I think both GLP-1 receptor agonists and SGLT2 inhibitors have been at the forefront of that paradigm change in diabetes management, from simple glycemic control to complication prevention to direct organ protection. I think with time, we are going to see further earlier use of these agents and to help patients with type 2 diabetes protect themselves from cardiovascular disease, kidney disease, heart failure, and also with the advantage of losing weight without hypoglycemia and probable benefits on other diseases like fatty liver disease or metabolic dysfunction associated steatotic liver disease. Thank you for this opportunity to speak at this meeting. And over to Madam Dr. Shailaja Kale.
Yes. Thank you, Dr. Krishnan. It was really an interesting case. So I request Professor Merlin Thomas to have his deliberation. He has to share his slides, Nikita, right?
Yes.
Just one moment. I'll be right there. Well, good afternoon, everyone, and thank you for the opportunity to be speaking with you today on such an important topic. The good news for all of you is that because you're all passionate about diabetes, because if you weren't passionate about diabetes, you're not only in the wrong meeting, but you're in the wrong job. And indeed, you're on the wrong country, because everybody in India needs to be passionate about diabetes, because it's going to be the major reason that people come to hospital, major reason that people come to see doctors, and as you've heard, a major reason for morbidity and premature mortality. But importantly, when considering the management of diabetes, often the first foot through the door might be hyperglycemia or poor glucose control. But of course, the beast that is adiposopathy or cardiac renal metabolic disease is much more complicated. And that considering the overall risk, as you've heard already today, is so much more important in managing patients with diabetes and improving their outcomes than just controlling their glucose levels. I like to think of the disease as what's called caramel disease, which is cardiac, renal, adipometabolic, and liver disease. And it has organ-specific manifestations, such as when the disease affects the ability of the pancreas to control glucose levels, you get diabetes. When it affects the ability of the liver and the systems to control lipid levels, you get dyslipidemia. When it affects the heart, you get heart failure and sudden death. When it affects the liver, you get fatty liver. And of course, when it affects the kidneys, you get progressive chronic kidney disease. These are all organ-specific manifestations of a central problem. And of course, you in India, in primary care in particular, are used to managing patients in this holistic way. It's never just diabetes that comes through the door. It's all of these other things. And mitigating all of these other risks is part and parcel of managing the care of patients with diabetes. One of the key things that you've already heard in the talk earlier in the symposium was that when we have someone with diabetes, often we need to consider their cardiac and heart failure risk as a routine part of their care. So every time we see the first foot of hyperglycemia, we think about the next foot of cardiovascular risk and heart failure risk. And certainly everyone with diabetes should be assessed for what their cardiovascular risk is, using an appropriate risk engine. And of course, when you do so, and the data beautifully shown already, you find that most people have elevated cardiovascular risk that warrants intervention. Equally, when you look at heart failure risk, whether you use a risk engine like WatchDM, whether you measure natriuretic peptides, or whether you do an echocardiogram, what you'll find is that patients with diabetes have higher rates of heart failure risk, and higher rates of hospitalization. And understanding that risk means that you mitigate it. And of course, that is why the patient that was presented earlier was on a statin, because they had high cardiovascular risk. That is why you're looking out for heart failure, in particular using a RAS blocker in that setting, because of the high risks associated with diabetes, cardiac disease. But in the same breath, it's also important to consider everyone with diabetes, everyone with cardiac disease or heart failure is also at risk of kidney disease, because it's the same process that's going on, manifested as impaired kidney function or increased urinary albumin. And about half of all people with diabetes will have some form of chronic kidney disease. And at least a third of those with high blood pressure, regardless of diabetes, will have kidney disease. And obviously in my country and in many countries like yours, diabetes has become one of the leading causes of end-stage kidney disease. If you have someone with diabetes in your practice who doesn't have kidney disease, there's a roughly 1 in 5 chance over the next 5 years they're going to develop kidney disease. And that is why it's generally recommended that everyone with diabetes is screened for chronic kidney disease. So that means measuring a urinary albumin and estimating their GFR on a blood test in everyone with type 2 diabetes yearly from the time of their diagnosis. You can't wait for symptoms. In fact, you lose 90% of your kidney function before you develop symptoms of kidney failure. So it needs to be detected by you. You know, patients won't know they've got kidney disease. In fact, passing more urine is a sign of failing kidney function, and they might think, actually, no, I'm doing very well because I'm passing more urine. Can't have a kidney problem. Actually, they might do that. And by screening with albumin, urine, GFR, we can identify people with kidney disease. But the important thing is not their level of GFR or their level of albuminuria. Just like with cardiovascular disease, the important thing is their risk. And here, looking at the risk of end-stage kidney disease, you can see from the green zone the risks of developing kidney failure, ending up on dialysis or needing a transplant, significantly increases going to the right as your albuminuria increases, or going downwards as your GFR declines. And that gives you an indication of what their risk is, but also determines your next actions. But critically, it's not just kidney failure that you're seeing risk. When you see albuminuria or reduced eGFR, you can see, for example, in the top, in terms of mortality, as you go to the right with albuminuria or as you go down, increasing risk of all-cause mortality. Whether you look at cardiac mortality, whether you look at heart failure, whether you look at hospitalization or heart attack, the presence of albumin in the urine and then GFR tells you about their not only kidney risk, but also cardiovascular risk, COVID risk, heart failure risk, mortality risk, and risk of adverse drug reactions as well. And it's just like traffic lights. You see someone within the green zone, they've got low risk. They're seeing someone yellow, moderately increased, orange is high, and red as a very high risk of developing all sorts of complications. Many doctors think that you can just get away by measuring the GFR because, of course, that's the marker of the function of the nephrons. But if you only test the GFR, you miss the opportunity for understanding the risk early and potentially mitigating it with appropriate therapy. And just an example, if you have an individual with an eGFR of 71, and you don't measure the albuminuria, as many doctors don't, because they go, oh, GFR is fine, there's nothing I need to do. You could be having someone in the green zone at low risk, or right on the right in the red zone. And you would not know unless you measured the albuminuria. And this is tantamount to kind of what happens with traffic lights. Of course, on the left here is a doctor who sees the orange light and appropriately responds. Here is the usual driver down your streets in India, where there's no orange light at all. It's go, go, go until it says stop. Here is the cyclist, which is go, go, go all the time and ignore the lights entirely. Here is the pedestrian, which is avoiding the traffic at all times and worried about cars all of the time. And here is the dog who doesn't see any lights at all. And so the question is, how do you manage kidney disease? Are you the doctor who responds to the orange light? Or are you a dog who doesn't look at the lights at all? And that's the problem, is that many doctors just don't see albuminuria, much like they don't see the traffic lights. Of course, if you measure albuminuria and you measure GFR and you find that the light is green, the important thing is that it does not mean do nothing. I'm teaching my son to drive at the moment, and I ask him what the green light does. He says, speed up. I said, no. He says, don't worry, do nothing. No, that's not a green light. A green light is a warning light. There's a warning light that there's an intersection coming up, a cardiac and renal and metabolic intersection that's coming up. Now, you need to be aware that the lights could change at some point. You need to be aware that there are crazy things that happen at intersections. There are pedestrians, there are people who run lights. You have to be aware that if you have a green light, it doesn't mean do nothing. It means proceed cautiously and continue to monitor. And that's where serial monitoring and screening is so important. But of course, if the light is orange or red, it means that you need to act if it's safe to do so and monitor even more closely. And if you miss the red, then you're dead. And that really is happening so often in our patients because we're not looking for their risks. In terms of mitigating their risk, it's very clear that what you can do now is that if you find someone in the in the yellow zone, you slow their GFR decline, you reduce their albuminuria, you assess and lower their cardiovascular risk, you avoid superimposed insults, and then you practice positive lifestyle changes. And then if you find someone in the orange zone, you do all of these, but you add in additional screening for and management of kidney complications, more appropriate monitoring and appropriate referral as required. And of course, if you're in the red zone, you're really in trouble. You have to be able to provide additional support as required. And that allows you to be able to pull out the stops when necessary. Now, in the past, we would have said in a patient who has got a reduced eGFR or elevated albuminuria, we would say, well, we just need to improve their risk factors. That's all we need to do. But we did an ACCORD trial, which very intensively lowered the blood glucose levels. But the trial, as you know, was stopped prematurely because of increase in death and death from cardiovascular disease that was chiefly due to patients with chronic kidney disease. So not only was there an increase in death, but actually there was no effect at all on the decline in kidney function by glucose control. Equally, blood pressure control in patients with diabetes. We go, oh, they've got CKD, I must go harder on the blood pressure. But in fact, harder on the blood pressure in the red line shown here does not give you better kidney function. It gives you virtually the same slope and overall lower levels of kidney function compared to standard of care, getting the blood pressure below 140 millimeters of mercury systolic. So it's not blood pressure, it's not glucose. And that's why the guidance has changed to say that we need to manage diabetes differently and holistically. And when you have someone with diabetes and CKD, the foundation is obvious. It's diet, lifestyle, monitoring, education, and adherence. Those are the important things. Nothing will work without those things. And then you add in as the central core of management an SGLT2 inhibitor, a RAS blocker to optimize blood pressure control, and a high-intensity statin to lower their cardiovascular risk. And once you've done that, then you assess what risks remain: glucose, weight, blood pressure, lipids, and then further improve on that basis. So you've got that background of SGLT2, RAS blocker, and statin. But if we focus for a moment, why is it that now everybody with diabetes and CKD is now recommended to be on an SGLT2 inhibitor? And this really began from trials like the EMPA-REG outcome trial. As you know, it was done in patients with diabetes and type 2 diabetes and cardiovascular disease. But roughly half of the individuals in this trial had chronic kidney disease. 29% in the yellow zone, 15% in the orange zone, and 8% in the red zone of very high risk. But importantly, when you look at the benefits that you saw, and of course, you've heard already about the reduction in cardiovascular mortality of 38%. But interestingly, the reduction was seen in all groups of kidney disease. But look, if you can, at the figures inside the brackets. You can see very clearly those with high-risk kidney disease, and particularly very high risk, are much more likely to have a cardiovascular death. hugely more likely than the low risk. And they equally benefited overall from being on an SGLT2 inhibitor, which meant that the absolute benefits of being on an SGLT2 inhibitor were absolutely greater in patients with chronic kidney disease. Equally in hospitalization for heart failure. Look who got hospitalized for heart failure. It's 11.8% in the very high risk in the placebo group, down to 6% with empagliflozin. So who are you going to treat with an SGLT2 inhibitor? Obviously, those at the highest risk stand to get the greatest benefit from using this kind of therapy. But importantly, it was also clear from this study as a tertiary outcome that being on an SGLT2 inhibitor significantly reduced your risk of developing kidney failure. Again, look at the figures in the brackets between placebo and empagliflozin. You can see those in the very high risk, of course, had the very highest rate of developing kidney failure, but that was significantly reduced by empagliflozin, as it was in all of the groups. But again, the absolute benefits were greatest in those at highest risk. Importantly, when you look at the rate of decline in GFR across this trial, stratified for the risk group they were in, green, yellow, orange, or red. If you were in a green, yellow, or orange group, essentially you were treated with empagliflozin, there was no loss in kidney function at all during the entire trial. It was absolutely flat. So in totally protect against all decline in kidney function. Whereas in the high-risk group, there was a slowing in the decline in kidney function, but there was still some loss because these were obviously very damaged kidneys, but a 71% reduction in the rate of decline in kidney function. And when you look at this trial from EMPA-REG outcome trial, and more recently the trials done in patients with diabetes, in the EMPA-Kidney trial, which included around about 44% of their patients had diabetes. The DAPA-CKD trial, where about half of their patients had diabetes, and the Credence trial, where they all had diabetes. You can see the grey line representing the rate of decline in kidney function in the placebo, the coloured representing the SGLT2 inhibitor. So you've got somewhere between 71 and 59% on average, very consistent effects, slowing the decline in kidney function in all of these studies, improving the rate of decline in kidney function. Equally, the EMPA-Kidney trial was the first trial ever to look at patients with low eGFRs, but also relatively low or modest increases in albuminuria. So, for example, the Credence trial only looked at this high-risk group with albuminuria above 300. But even in the lower albuminuria group, of course, lower albuminuria means slower rate of decline, but still they've got impaired kidney function. But even there, it was slowed by relatively the same amount. In fact, 88% slower compared to placebo. And really damaged kidneys, of course, there was less effect because you can't undo some of that damage. And you might say, oh, GFR decline 50%. What does this really mean for my patients? Well, let's put it into perspective. Imagine that you've got a patient with an eGFR 45 and microalbuminuria. His rate of decline in kidney function, you calculate roughly 3.3 mils per minute per year, which is about an average what you see in these trials. So you can say that from an eGFR of 45, he's got roughly 10 years before he develops renal failure. But if you add an agent that slows kidney function decline by 50% or more, what that means is 10 years becomes 20. So now you've added 10 years to his kidney or more. If it's 70 or 80%, it's probably more like 15. But overall, at least 10 years to his kidneys when you've acted relatively late with an eGFR at 45. And this is why we see in the real world data from things like EMPRISE, when doctors just like you decided, right, I'm going to put my patient with CKD stage 3 or stage 4, in other words, an eGFR below 60, but above 30 probably in this particular study. I put them on an SGLT, I put them on empagliflozin specifically. You can see the dotted line representing empagliflozin and the standard line represented standard care with a DP4 inhibitor. So almost halving the rates of developing renal failure, not over 20 years, but actually within 2 years of therapy. But what's really interesting is that in this study, it also is clear that patients with CKD stage 3 and stage 4 were half as likely to end up on empagliflozin than patients with high levels of kidney function. So the same group of people who benefit the most from empagliflozin were the least likely to get it because people were afraid or concerned about risk. But importantly, the best time to give an SGLT2 inhibitor is earlier. So for example, when the EGFR was 65, much earlier, and his microalbuminuria was there, and his rate of decline in kidney function in the future was there, so now he's 15, 16 years away from dialysis when his EGFR is 65. If you then started an SGLT2 inhibitor, as you should when he was in the yellow zone, slowing his rate of decline in kidney function, lowering his albuminuria, not only could you have added at least 16 years extra to his kidney, he probably never would in his lifetime develop renal failure because you started early and in time. Equally, if you said, "No, I'll wait and see what the nephrologists have to say. I'll ask him to start the drug." And of course, when he comes with an EGFR of 30, sees the nephrologist goes, "Well, I better start an SGLT2 inhibitor," and goes, "Wow, what a tremendous effect. I've delayed kidney function for 5 years." But you in the real world know 5 years is not enough of an add-on. It's not enough. And it's great for a nephrologist to give him time to put a fistula in or prepare for end-stage disease. But waiting for the light to go red before acting is not a very good solution, whether you're driving in traffic or you're dealing with chronic kidney disease. The major reason why people do not initiate an SGLT2 inhibitor is they're worried about the risks associated with it. And all of you will know is that starting an SGLT2 inhibitor has an immediate drop in kidney function of about 7%. And I mean percent specifically because it's a really percent of the background level of function. So whether your EGFR is in the mid-60s, like it was in EMPA-REG outcomes, in the mid-30s, like EMPA-Kidney, or much higher in EMPA-reduced, the higher levels of kidney function, like the dotted line, have a bigger drop of kidney function than those with a lower level of kidney function, such as those in the full line. So as a percentage, it's exactly the same, roughly about 7% drop. But that's the same drop like you drop speed when you put the brake on coming up to a traffic lights. You feel that initial shudder where you start that brake off. That's exactly what happens with an SGLT2 inhibitor. It doesn't mean you've broken your car. It means you've started the slowdown process. And it's not dangerous, and in fact, it's fully reversible. The reason that people were worried about is that when you do this with a RAS blocker, that drop in GFR is associated with increased risk of acute kidney injury. But in fact, in all of these trials, the risk of acute kidney injury was actually reduced by empagliflozin rather than increased. So do not monitor for it, do not worry about it, and do not use this as a reason for not using this life-saving medication in your patients with chronic kidney disease. So really, I want you to imagine how seriously we take road traffic accidents. More people die across the world from chronic kidney disease than actually road traffic accidents. And we try and prevent road traffic accidents by having lights. They tell us what the risks are, because accidents happen at intersections, when to slow down and when to avoid things. The same should happen with CKD. We should put lights up on all of our patients to know what the risk is of an intersection between cardiac, renal, and metabolic, so that we can avoid those kind of accidents, slow on the oranges, and not really miss the red. Focus on slowing the decline in kidney function and dealing with all of the other risks of heart failure, the cardiovascular risk, and then adding on additional or more intensive monitoring and therapy as the additional risk requires. But please, the message really is don't wait for the red light before you go, "I want to slow down." When you see those early signs, when you detect albuminuria, it is an opportunity to make a difference to the lives of your patients. So identify those risks early so you can act in time. And what we want to really get the message out is that that as we talked of earlier, it's so important to think holistically about our patients. It's not just that first step of hypoglycemia, but by managing their cardiac risk, as you heard in the first talk, and now their renal risk, we can keep our patients healthier, out of hospital, and particularly alive for longer. And the chance begins when we identify risk, whether it's cardiac risk, when we do an ECG, or heart failure risk when we look at their risk calculator or their BNP, or their kidney risk, whether we look at their albumin, GFR. We stratify risk so we can improve their outcomes overall. And with that, I'm going to stop my share and hand it back to our chair, who's going to lead us in our discussion. Thank you.
Yes. Thank you, Dr. Malin. It's beautiful and lot of things inside, but made it very simple. And it was very, very simple to understand. As I said initially, I think all my colleagues must have heard the same things, but in a very different thing, which was more impactful. So thank you so much for that. So I think first for everyone, I will just like to say the first take-home message today, what Dr. Merlin has given is that you need to check both urine albumin creatinine ratio and GFR at every visit. At least there has to be there. So only checking sometimes only USCR, that how much is albumin, is not sufficient. You miss out on a lot of other things with the low GFR. As well as only GFR is not sufficient. We need both. So when you put KDIGO heat map, you know, this left side upper corner and the right extremes, but you can map your patient wherever it is in the whole this heat map and can treat. So checking both is crucial. That is the first take home. Then only A1C control is not sufficient. We need blood pressure, we need lipids, we need drugs and SGLT2 inhibitors, the wonderful drugs which we can start early. I really liked how we can prevent this 10 years time when the patient is reaching towards dialysis, and we can just postpone it by more than 10 years if we start early. So that was very important take-home message. And so I would like to start some important questions which people have in mind. So let me start. What about these two ends of the spectrum? So we discussed at the very normal GFR and less than 30 albuminuria, it is still significantly reducing the risk, which you showed compared to placebo and the percentage which we saw in brackets. What about the extreme end when the GFR is below 30? Now I think it's the cutoff is 25. But we see a lot of patients with very severe proteinuria, ends of diabetic kidney disease, not reached end stage. But can we use in the very low GFR settings all these SGLT2 inhibitors?
The trials that have been done so far have had cutoffs for enrollment. So, for example, in the EMPA kidney trial, patients had to have an eGFR above 20 to initiate in that particular study, and above 25 or so in the Emperor trials. Now, obviously in these trials, their eGFR dropped below that, and there was no sense that there was any safety signal at all. So they can be used safely in patients with an eGFR that is low. In terms of initiating when an eGFR is low, particularly below 20, there's less experience, and often there's a recommendation not to do it because there's no experience. In truth, what I'd much prefer is you'd started much earlier. But even in the late stage, you can initiate, and they can be used safely. But in truth, it's much better to initiate earlier. It gives you more time and more wiggle room in terms of safety overall. Now, having said that, there is currently an ongoing trial of initiating patients with an SGLT2 inhibitor with an eGFR below 15, or on dialysis, or a transplant patient. Now, we don't know what's going to happen in that particular trial simply because things work differently in renal failure. We had a trial of statins in dialysis patients that was completely ineffective. And then we didn't realize that. So risks are sometimes different in end-stage kidney disease, and so we need the trials to inform us. But please, let's make no patient ever develop end-stage kidney disease so we won't have to worry about this. Let's initiate much earlier when we see the risk.
Yes.
Everyone who gets to an eGFR of 30 used to have an eGFR of 60. So let's get in before that happens so we can use it safely and effectively rather than try and mop up the pieces when it's really, there's not much, few nephrons left to save.
Yes, I completely agree because I think first SGLT2 inhibitor trial published was EMPA-REG, and then all these trials. So there was so much of discussion of heart failure that came up. Then slowly, because of the credence, it went to the kidney. Though these drugs initially had a research basic, how to reduce proteinuria, I think, all SGLT2 inhibitors. Then, but because of these trials, the discussion went to heart failure and the kidney. So I think perception among most of the doctors' mind is these drugs are for these indications. So like this gentleman, which we saw in the case Dr. Unni said, he must have been on SGLT2, must be on SGLT2 inhibitor right from diagnosis, so that we can prevent. It should be all the SGLT2 inhibitors should be used right at the diagnosis, especially in India, with such a high risk population, which we are seeing the subgroups which are more prone for all these complications. So I completely agree there. Another question I want to ask Dr. Undi is, in your case, there was a increased SGPT and OT, which was quite high. Like usually we see 60, 55 kind of a figures. It was 140, 150 liver enzymes. And so what are other investigations one should do when we see these type 2 diabetic persons with just raised liver enzymes, just to have to know the NFLD risk?
I think usually, as you said, the liver enzymes aren't so high, and in this case, it is pretty high. So I think some tests to rule out a secondary cause of liver disease is important, like the anti-HCV, IgG, and the HbSAg. If you suspect hemochromatosis, you can order ferritin and Wilson ceruloplasmin. Those are very rare conditions. Probably in today's world, it's still likely to be MASLD or metabolic dysfunction associated steatotic liver disease. So once I do a basic viral markers and I find that they are negative, maybe look at looking at the ultrasound and a fibroscan, one could make some idea about how to go ahead. Another good tool is a FIB4 screening tool. You just need an AST, an ALT, and a platelets, and you can stratify as to low risk of fibrosis, intermittent risk of fibrosis, and high risk of fibrosis. I think low risk is below, I think 1.3 to 2.67 is intermediate risk, more than 2.67 is high risk. So you can use that to stratify patients who require further evaluation. The diagnosis is still MASLD, I feel, and of course you can do viral markers. Many of the patients are now coming with these kind of adipose fatty liver disease along with these enzymes. I think there's also there is an Indian drug which is approved, which is saroglitazar. There is also evidence from India, a randomized control trial published from Delhi in the journal Diabetes Care, which looked at empagliflozin for NAFLD and showed a reduction in hepatic fat. So now we have, and we know that GLP-1 also is effective. In fact, we have 2 trials published in the New England Journal of Medicine this week. One is survodutide, which is and tirzepatide. Both have shown benefits on MASLD and MASH. So I think this area is becoming very treatable and very exciting to see how it's evolved. And there is resmetirom, which is a thyroid receptor agonist, which also has been shown to have benefit in MASLD. So looking forward to this area expanding.
Yes, completely agree, because the slightly raised liver enzymes should not be overlooked. I think even fatty liver, and just look at the platelet count, have the score. And now we have this with the intentional weight loss and the lifestyle modification. I think all diabetes clinics should use these drugs to prevent the fibrosis in the liver. Empagliflozin, in way, I think I read the paper which shows that it's a biopsy proven paper published, which says it's a reduction in the fibrosis in the patients with NAFLD. Yes.
But the really interesting thing is that if you find someone with a fatty liver and abnormal liver function tests and whatever, their future is not probably going to develop liver cancer or liver failure. That marks them as a risk for having cardiovascular event, marks them risk for having heart failure, developing diabetes if they haven't got already, and developing kidney disease. So again, if you find risks, whether they're kidney risks, liver risks, heart failure risk, cardiac risk, again, you have to treat patients holistically. And the advantage of using an agent like an SGLT2 inhibitor in that setting is really, it's your first CRM agent. Not only are you treating the liver fat, but actually you're treating their cardiac risk, their heart failure risk, and their kidney risk, because you know that that's what comes with liver disease. You never treat liver disease just by going, oh, I want to get the liver fat away. You're treating your patients holistically, their cardiac risk, their renal risk, their metabolic and diabetes risk, as well as their liver risk, all together at once by prioritizing agents in that setting.
That's absolutely true. So I think nowadays there are a lot of things which we see the papers about distribution of the adiposity in the whole body and how it changes favorably with SGLT2 inhibitors as well as with GLP-1 analogs. Like we have seen the epicardial fat changes as Professor Merlin just mentioned about, you're not treating only the liver fat to prevent MASLD or the chronic liver disease or fibrosis, but it's an indication that you change the adiposity and which takes down the risk of heart failure as well as the chronic kidney disease much less. So yes, definitely. Just one question for which is a typical comes in the clinics, and many times SGLT2 inhibitors are stopped because of chronic urinary tract infections. And you always see that some other doctor will say, no, stop this because you have urinary tract infection, which you have prescribed. And then patient doesn't take it for 3-4 years till the patient comes back. So what is your take, Professor Merlin, that just a simple UTI, the pyelonephritis, recurrent UTI. So again, there is a spectrum when we say there is a urinary infection. So can we use it again once the infection settles down?
So this is an important reason why, in fact, many women aren't prescribed SGLT2 inhibitors, which is a tragedy because they have higher rates of chronic kidney disease and higher rates of heart failure, and not receiving an SGLT2 inhibitor because they're worried about UTIs. In fact, when you look at EMPA-REG outcome trial, 30% of women in that trial with diabetes in that trial developed a UTI during their 3 and a bit year follow-up. In the number receiving an SGLT2 inhibitor without having to stop it, without any titration, without doing anything, was actually 26%. It was actually lower, numerically lower with an SGLT2 inhibitor. So you don't routinely need to stop an SGLT2 inhibitor in a woman who develops a UTI, and nor does it increase her risk of having a urinary tract infection at all. Mycotic infection, yes. Urinary tract infection, no. In terms of pressing the pause button, I keep getting reminded that that kind of like the remote control in your TV, there's a difference between pause and stop. And so when we have a patient who's really sick, catabolic, not eating and drinking, it's entirely appropriate to pause, not stop, but pause the SGLT2 inhibitor in order to, for them to be get over that severe illness, for them to see you. But when they're eating and drinking, normally there's no reason that you can't start it again. So it's just pause and restart rather than stop, because I think you're absolutely right. There is a big danger in stopping therapy and never restarting it, resulting in essentially non-adherence and therefore loss of the benefit of that kind of therapy. We can continue using these therapies in most patients who have got mild illness. When there's severe illness like severe COVID or severe fever, or they're going in for surgery, it's appropriate to pause the therapy so we can reinitiate it again when they're eating and drinking normally, when they're out of the woods in terms of illness. Pausing therapy is appropriate as part of the SADMAN's rule, which is essentially sulfonylureas, RAS blockers, metformin, diuretics, ACE inhibitors, and as well as SGLT2 inhibitors. You press the pause button on them during periods of not eating and drinking, and then restart afterwards. And it's really important that these drugs can be used safely in women and have been trials be used safely in women. So even though you're worried about UTIs, and there's reason to worry about them, I'm worried about mycotic infections, they can be used and are used safely and can be life-saving in women.
Ma'am, you're on mute.
Yes, perfectly. So that's what I just wanted to stress it, because we all have seen patients with, euglycemic ketosis when these drugs started, especially mainly women with urosepsis. But as I said, there are so many patients, it's just a simple infection. So we may stop it temporarily or hold it and need to restart, treat that non-diabetic kidney disease, obstructive uropathy, whatever is the cause. Once the patient is out of that, we need to restart. And maybe occasional patient, we may need to have to stop it completely, but most of them, they tolerate it again. So it should not be a knee-jerk reaction to just stop SGLT2 inhibitor whenever you see any urinary tract infections. Uni, anytime you want to add anything or comment, you're most welcome. Just one question, which I think we see a lot of type 1 patients with heavy proteinuria. And really we can't do. I know finerenone trials are going on, but still I always see the comparison. The death because of diabetic ketoacidosis are much more in type 1 patients when the patients are put on SGLT2 inhibitor. That's why it's contraindicated. But what's your thought about these type 1 patients with proteinuria for use of SGLT2 inhibitors in these individuals?
It is a tragedy that we can't safely use something so powerful in patients with type 1 diabetes. There was a few, just over 30 enrolled in EMPA-KIDNEY trial, and they showed a slowing in their decline in kidney function by using an SGLT2 inhibitor. So you're absolutely right, it works, but the number needed to harm is very small. It's something like 40. So 40 treated, one ends up in hospital from ketoacidosis. And that ketoacidosis in type 1 diabetes can be fatal. Not euglycemic ketoacidosis sort of evolves and grumbles on over a couple of days where you get sick. You can go from being perfectly healthy to being moribund in a matter of hours with hyperglycemic DKA in type 1 diabetes. And anything that increases that risk is just way too dangerous. And I've had a number of nephrology colleagues that said to me, I thought, because they got proteinuria and they're developing kidney failure, I'd had to do it and had to use an SGLT2 inhibitor until one of my young patients just never made it to hospital, just died. And, she lived close to hospital, she didn't make it. And he said, I'm never doing that again. It was just too scary. So do not prescribe it in type 1 diabetes. There's no way that you can mitigate the risk of ketoacidosis. It's too profound and it's too dangerous to be using it in someone with type 1 diabetes. This is pure type 1 diabetes, not maybe a little bit on the spectrum, but this is antibodies, no C-peptide. You simply cannot use it safely in that setting. One day we might get a different therapy, but at the moment SGLT2 inhibitors are just way too dangerous. Even though you might think it works, they're just way too dangerous.
Well, if you're looking at the renal outcome evidence, there was one, the only renal outcome evidence with type 1 diabetes included was a sotagliflozin trial. Soloist trials actually looked at both type 1 and type 2 diabetes together, and they showed a reduction in renal events. But there was an increase in diabetic ketoacidosis, and in India, people may not come for follow-up. It's really sad that this drug, which is approved in type 2 diabetes to prevent kidney disease progression, even approved in non-diabetic people to prevent kidney disease progression, sadly cannot be used in a type 1 diabetes patient with a low eGFR and proteinuria. But the truth is that we just can't take the risk. In India, there is this new trend of type 1 following a low-carb diet. So many of the type 1 diabetics patients in India are actually following a keto-like diet. So some of them are checking their ketone levels and managing an A1C of 4.85 with say 10 units of insulin, 5 basal and 3 boluses. And that makes it even more risky if they take a SGLT2. So I think in India, we should not be prescribing it in type 1 diabetes. But as you said, it's a tragedy that we can't use it in a type 1 diabetes when it's already approved for type 2 diabetes and even in non-diabetic kidney disease.
So I think both experts are on the same. It's a very, very important advice because I keep on seeing prescriptions and many of the nephrologist colleagues have written the prescriptions for SGLT2 inhibitors for type 1 patients. So I think it's our, again, duty to see and again explain and please not to use these drugs in type 1 diabetic patients. So that comes again. So any, you have some take-home message, Dr. Unni, from today's discussion?
My main plea to doctors is that this is a drug which is going to eventually reduce cardiovascular death, prevent the decline in EGFR, prevent the need for renal replacement therapy. The only thing is that to get the maximum benefit, SGLT2 inhibitors, especially empagliflozin, which reduces CV death, has to be prescribed pretty early when there is a clustering of cardiorenal risk factors, metabolic risk factors, which is in many of the people. So I think as a clinician, let's be astute enough to spot that and discuss with our patients the benefits. There are some risks, but I think the benefits far outweigh the risks, and let us use it to help our patients to lead a life of complication-free life of health and wellness.
Yes, thank you. Professor Merlin, any take-home message for my friends who are listening?
Well, thank you. Look, thank you for the opportunity to speak with you today. I think the opportunity now is going to be to embrace SGLT2 inhibitors wherever we see risk, wherever we see cardiac risk, where we see renal risk, where we see liver risk, where we see risk of poor outcomes, to bring it into our care as part of a foundational therapy, and then build upon that better glucose, blood pressure, lipid, and weight control upon that. Already we're starting to see in my country, everyone who gets a GLP-1, in other words, they had to be enough for risk for be on a GLP-1, had to be on an SGLT2 inhibitor first. And so because the costs have come down, because the availability has increased, I think there's no reason that we can't think of using these agents very early in combination with the other strategies that we use to lower glucose levels. And, on their own, SGLT2 inhibitors are never going to get A1Cs all below 7. You're going to still need that DP4 inhibitor and metformin on board. But I think that triple combination of a DP4, SGLT2, metformin, and oral therapy it's really going to become standard of care for everyone early on, because everyone early on has got signs of risks of liver problems, of cardiac problems, of heart failure problems, of kidney problems. And if we can slow that rate of decline down, then we can, as Dr. Ernie says, protect lives considerably by using this as foundational care. Thanks.
Yes, thank you. So I really loved the take-home message, the whole session. And your concept of showing the traffic lights was beautiful, that green is just not go. It's a warning. That was a very good message. That's what I felt. So thank you so much, both the great gentlemen and the great experts today. And I thank all the attendees who have joined. I thank Dr. Nikita for initiating this session. And also we thank Boehringer Ingelheim for giving us opportunity to talk to Professor Merlin. Thank you so much.
Good evening.
Thank you. Pleasure to be here.
Thank you, everyone.
Recording stopped.